It is my just absolute and total delight to introduce today's speaker for the seminar series. The last of this academic year for ASU. Sorry, everybody that's on quarter systems. Today's speaker is Professor Melanie Martin from the University of Washington Department of Anthropology. Professor Martin earned their BA in anthropology at the University of Puerto Rico, where she studied in a skeletal collection of macaques the relationship between parity and tooth loss to investigate the conventional wisdom, a tooth per kid, that has been discussed extensively among biological anthropologists, looking at the relationships between skeletal health and reproduction. She then transitioned to pursue her PhD research in anthropology at UC Santa Barbara, and technically the integrative anthropological sciences, and studied lactation, physiology, breastfeeding, decision-making, and family dynamics among the Tsimane. Following her PhD, she went and did a postdoc with Professor Claudia Valencia at Yale University, looking at lactation and breastfeeding and parenting decisions among the Toba, as well as continuing work in the Tsimane population, and has just been a powerhouse of a rising star within the biobehavioral dynamics of lactation within traditional human populations. So please join me in enthusiastically welcoming Dr. Martin to present to Tsimane today.
Thank you. Let me share my screen. Okay. Sorry. Here we go. Okay. So I should say I did do my undergraduate work on monkey skulls with teeth, but not in relation to parity. It was free range versus captive health implications, but that would be a fun project to go back and do. So thank you, Katie, for the introduction. Thank you, Noah, and the other organizers for having me. I'm happy to be here today and talking to you about my ongoing and some recent work that I have been doing in the areas of birth mode, breastfeeding, and health outcomes. And let's see. Gosh, nope. You'd think one day I'd get it. Okay, so I wanted to start particularly because for the students that are attending by discussing some of the overarching principles from evolutionary medicine and anthropology that inform all of my research. The first being that what we consider normal biological functioning and optimal versus suboptimal health outcomes are context dependent. They vary across time and place in different human environments. And then secondly, what we consider optimal health, even within those contexts, involves trade-offs. And that can be trade-offs in the traditional sense of life history stages or energy allocation, but also importantly, I think, trade-offs in time allocation and how we direct our energies towards health in different contexts of our lives. So for example, whether I choose to go out for a vigorous run every day to support my cardiovascular health, even when it's crappy Seattle weather, or whether I just prefer to sit on the couch with my family and watch Emilio Estevez in the new Mighty Ducks television series. Now, if we combine these two principles together, I think they're important in helping to devise successful health interventions, because those types of interventions really require an understanding of the biological mechanisms that underpin health outcomes, and of course can vary in these different context-dependent pathways. And importantly, at the same time, successful health interventions should be behaviorally feasible and culturally acceptable, which anthropology provides. And if there is one thing that we have learned in the past year of this pandemic is that public health policy and messaging often fails to account for human behavior and culture. And so while that is neither here nor there, I can move on to how I'm interweaving these topics in the talk that I'm going to present today, which examines whether cesarean section is associated with suboptimal breastfeeding outcomes in the indigenous calm in northern Argentina, which have traditionally strong support for breastfeeding. All right, so I'm going to first give an overview of what the links between cesarean section and suboptimal breastfeeding outcomes are, including defining what I mean by that. I'll then present some background information on the calm study population and our study design, then show you the evidence of the associations we observed between cesarean section and exclusive and total breastfeeding durations, and then return to a broader question about what is really suboptimal then in the context of breastfeeding, and how that can inform some frameworks for evolutionary medicine research on birth and breastfeeding practices. And still, before I really dive into that, I want to acknowledge all my colleagues who have contributed to this work. My collaborator and director of the Chaco Area Reproductive Ecology Program in Argentina, Claudia Valegia, our field coordinator there, Sofia Almeida, and Lisandra Mancia, our primary research assistant. And then at UW, the University of Washington, my postdoc, Monica Keith, and several graduate students and undergraduate students who have worked on part of this data. And because I'm going to be talking about birth and breastfeeding and public health implications, which can be a very contentious discussion in certain circles, I think it's important to explain my positionality in this topic. So I started, as Katie mentioned, I started working with the Tsimane over 10 years ago, studying how moms make feeding decisions, how they make decisions about transitioning from exclusive breastfeeding to complementary feeding, and then how that transition affects their reproductive outcomes and infant growth and developmental outcomes. And then I began working with the COM in Argentina, similarly looking at studying growth and development and breastfeeding and birth more recently. And in between all of that, I also became a mother. So I am also now a person who has given birth and lactated. And so my research is also informed by that lived experience in the particular context of being a white woman in the US. All right, so when I talk in the beginning of this talk, at least, or the framing of this talk and the data that I'm going to present, suboptimal and optimal feeding practices are defined according to the WHO criteria for optimal feeding practices, which are initiating breastfeeding within 1 hour of birth, then exclusive breastfeeding for 6 months, the first 6 months of life. So that means no other liquids, including formula or solids before 6 months of age. And then breastfeeding with complementary feeding for 2 years or more. So really what's meant by that is total breastfeeding durations of at least 2 years. And these recommendations derive from epidemiological research showing lower morbidity risks, lower mortality risks for infants that mothers and infants that conform with these feeding practices. Now, there's several plausible pathways, though, by which cesarean section can lead to suboptimal breastfeeding outcomes, including non-initiation of breastfeeding and earlier complementary feeding or earlier weaning before those targets. So primarily, because of maternal separation, maternal recovery related to cesarean section, mothers who are recovering from that surgery may have early problems, either initiating breastfeeding. Infants might have problem latching, they might have problems with early milk production. And so that can result in persistent problems with breastfeeding, latch, and milk production, requiring mothers to supplement early on, continue supplementation, so early complementary feeding. And then because milk production occurs on a positive feedback with demand, continuing milk production, that can ultimately lead to earlier than desired weaning. Another possible pathway is that because of the altered microbial environment that infants experience when they're delivered via cesarean, that altered gut microbiome might promote more rapid growth. Mothers may perceive that rapid growth or respond to that rapid growth by introducing complementary supplementary feeding earlier on, again, potentially leading to more supplanting of breast milk and earlier than desired weaning. Now, the problem, however, in looking for evidence of these associations in observational studies is that cesarean section itself, the likelihood of cesarean section, is also associated with a host of maternal, fetal, and sociostructural factors. So for example, premature birth, maternal obesity, low infant birth weight can all be a risk factor for cesarean, and in turn are independent risk factors for, say, early breastfeeding problems like latch and delayed lactogenesis. There's also, for example, some populations in which maternal preference for scheduled cesarean tends to correlate with maternal preference for not breastfeeding or for not breastfeeding very long. And lastly, there are a lot of socio-structural influences that promote higher rates of unnecessary, medically unnecessary cesareans that could also be correlated with socio-structural barriers to breastfeeding beyond the immediate postpartum period. So looking causally at associations between cesarean section and breastfeeding can be a little fraught. All right, so returning now to the study population for the data that I'm going to present today. These are the Calm, formerly known as the Toba. They were traditionally hunter-gatherers that spanned the Gran Chaco region of Latin America. Today are concentrated mostly in forced government settlements around northeastern Argentina. The study community that we work with are in the West and the East. For this particular study, we were working with a community of Eastern Calm in the peri-urban community of Nan Calm, which are just outside the capital city of Formosa in the northeast region of Formosa. And Formosa, just for context, is one of the poorer provinces of Argentina. Okay, whoops, I didn't want to go there yet. Okay. So my collaborator, Claudia Valegia, she's been working with community members in Nam Calm for over 20 years and has documented throughout this time that Calm mothers pretty universally breastfeed. They might bottle feed with artificial milk when available, but they don't really have the they don't really have the money or the access to frequent formula feeding. They also very much value breastfeeding, and there aren't really any barriers to breastfeeding. There's no taboos about breastfeeding. Mothers sleep with their babies. They have few economic opportunities outside the home. So they also are very rarely separated from their infants. And now that all said, so while their breastfeeding practices seem to be pretty traditional in the time that we have been working with them, and also more emblematic of what we would consider intensive breastfeeding practices throughout most of human history and evolution. That said, their births have been pretty highly medicalized over the last 20-30 years. So in a recent study we published from interviews and reviews of birth records of 101 mothers and infants We observed that we knew that 90% of them gave birth at a public urban hospital. Healthcare for Qom families is free, provided by the Argentinian government. They also have access to prenatal care at a clinic located within the Nam-Qom community, and mothers had on average about 6 prenatal visits. So prenatal care isn't a barrier for them, and they're all giving births at hospital. We did observe in the same study, however, a pretty alarmingly high rate of cesarean section of 46%. So the estimated rate of medically justified cesarean section is about 15 to 20%. Now, in our review of birth records, we only observed that 10% were explicitly justified in the records of in the birth records itself, where there was a note about some maternal condition or fetal condition that would probably warrant a cesarean section, but there weren't any records of whether the cesarean was scheduled or unscheduled. That said, from some conversations with Qom mothers, we think it is very, very unlikely that Qom mothers ever prefer cesarean sections. So this was a quote from a mother who said, "My last birth was a very bad experience. Think about going from a normal birth to a cesarean," and I use normal birth, that is her descriptor. It's something very different. A normal birth, you have your baby and right away you can get up and do your things, but with a cesarean, no. You always have to be dependent on whoever can help you, whoever is at your side, no. So this has been voiced by other women, and many women have voiced fear and distrust of medical professionals and the hospital in general. So combining all of this together, when we want to look at associations between cesarean section and suboptimal breastfeeding outcomes among the Qom, we can at least remove a few potential confounders, such as maternal preference for cesarean section, maternal preference for formula feeding or not breastfeeding, and socio-structural barriers against breastfeeding. So the results of some analysis that I'm next going to present, these come from data that were collected between 2011 and 2014, monthly interviews with 101 mother-infant pairs. The aims of this study were to observe infant growth and development in relation to feeding transitions. Within this sample, we examined only those that we had complete birth records on, so 89 infants that had birth records with complete information about birth mode, cesarean or vaginal birth, birth weight, and maternal age, and whether the mom was primiparous or multiparous. Then in 2019, myself and Sophia and Lisandra tried to contact as many of those mothers as we could for retrospective interviews to get more context about their experiences of that birth, because we had such limited information from the birth records. So their experiences of the birth and breastfeeding with those eco children. And so we were ultimately able to contact 54 of those, 48 of the moms, representing 54 of those births. Okay, so this is a Bayesian time to event framework, which accounted for interval censoring in the data. Our estimated time to complementary feeding was 23 weeks, and median time to weaning was 30 months. So average exclusive breastfeeding duration of just under 6 months, and average total breastfeeding duration of about 2.5 years. So this is a good thing because it suggests that breastfeeding patterns, practices have been relatively unchanged over the last 20, 30 years, despite medicalized births, other globalizing influences that might affect breastfeeding decisions. Now, then we next ran a full time to complementary feeding model, which included a random ID, a random effect for infant ID, as well as fixed effects for infant sex, birth mode, maternal age, so adolescent maternal age or more advanced maternal age, and infant gestational age. And as you can see here, in this analysis, all of the coefficient intervals from the posterior distribution span 0, and all hazard ratios spanned 1, as shown here. So indicating that none of these model parameters were associated with any consistent increase or decrease in time to complementary feeding. Now, in contrast, our full time to weaning model included sex, obviously birth mode, maternal parity, whether she was primiparous or multiparous, and gestational age, with this being pre to early term versus the reference of full term birth. And here we see that while primiparity was associated with significantly increased risk of earlier weaning, unexpectedly male sex, so male infants, pre to early term birth and cesarean section were associated with later weaning, a decreased hazard of weaning, and on average about 5 months. So cesarean section infants on average are weaned about 5 months later than their vaginally birthed counterparts. But I will add, in a downsample model, age of complementary feeding did not predict time to weaning, and most of the proportional difference in weaning is coming after 20 months. But most of the proportional difference between birth mode, between cesarean delivered and vaginally delivered infants, is happening after 20 months. So nothing in our results suggests that cesarean section is associated with early breastfeeding problems that would persist into continued breastfeeding problems, resulting in shorter exclusive breastfeeding duration and shorter total breastfeeding duration. And then our retrospective interviews give some additional context for these birth and breastfeeding experiences. So we asked moms explicitly about if they were given formula in the hospital to supplement their infants with, if they supplemented. 10 said yes, and of those, 4 had delivered via cesarean and 6 vaginally. There were another 4 mothers who reported that they had breastfeeding problems in the hospital but didn't supplement, and all of those were unscheduled cesarean section, but still no real strong evidence here, strong patterning of problems or supplementation in the hospital occurring more frequently with moms who deliver via cesarean. And importantly, of all those 14 mothers, only 1 mother reported continuing breastfeeding problems once she got home. And she also said that she continued to provide artificial milk for about a week, and then was able to revert to just exclusive breastfeeding. But calm moms do experience problems breastfeeding. When we asked them questions about their first births, so this was answered by 48 mothers, 52% reported that they did find it difficult to breastfeed after the first time that they gave birth. And 90% reported pain breastfeeding for the first time. And I really want to emphasize here, there's not a difference in maybe their pain perception or their ability to deal with pain, I don't believe, because they reported pretty extreme pain, things like cracked, chapped, bleeding nipples, burning sensations, everything hurting and feeling like your skin was peeling off. My favorite response was, "Es peor que las contracciones, se te rajan los pezones," which translates to, "It's worse than the contractions, your nipples will split apart." So extreme pain that they were experiencing. So the question then though is, how are they able to sustain their breastfeeding, despite any early problems and despite, at least in the case of first births, kind of extreme pain. There was a great talk by Abby Page, for example, a few months ago, showing that for women in the UK, pain was one of the major predictors of not being able to continue breastfeeding. But importantly, and as I'll get to, social support might have mediated that. And so that also is likely what's going on here. So at the same time as first-time mothers were, or when moms were talking about their first-time birth, they reported a lot of pain and problems. 71% also received direct help from their mothers and other female kin. Some examples here: my mother, aunt, and mother-in-law all stayed with me in the hospital to help me nurse and position the baby. And then another mother who said, I didn't have help, but learned to nurse quickly because I had seen my mom, neighbors, and other women doing it. So really supporting a framework that has been discussed in anthropology about how breastfeeding, successful breastfeeding, right, requires both observation and a lot of support for breastfeeding mothers. And this is something that is also echoed in some work that Brooke Selza and Katie Hine did with Himba mothers in Namibia. So similarly with first-time Himba mothers, they reported really commonly a lot of problems with latch, positioning, supply, and pain. But also they had their grandmothers who were able to move in with them, help them position the baby, give them direct instruction, and help to care for the moms as they recovered throughout an extended postpartum period. And this is a picture from that paper of a Himba mom nursing, and then her grandmother, a grandmother outside making food for her. And so this relates to themes I have discussed earlier. This is one of the assigned papers, that we really cannot, when we're attempting to evaluate breastfeeding practices, even on this map of what are patterns that might be typical biologically for our species of universal breastfeeding, frequent breastfeeding, exclusive breastfeeding for around 6 months, and breastfeeding for around 2 years, we can't separate that out from the feeding niche in which breastfeeding evolved in our species. And I have defined this as a specific mixed feeding niche where breastfeeding continues, but infants also rely proportionally on a lot of other foods. Their moms rely on provisioning and other foods. That involves higher quality diets. So this all involves cooperation, paternal care, and those things together were what enabled us as a species to actually wean infants relatively early, have higher fecundity, shorter birth intervals, all of these interrelated things. So it's hard to separate breastfeeding outcomes out of that context, or at least it's hard to try to emulate breastfeeding outcomes outside of that context. So some limitations of these results and other implications. First, I'll say with explicitly the data that we have, right, exclusive breastfeeding duration or time to complementary feeding may be a really poor proxy of early breastfeeding problems in this population. So that is suggested by, relatively no association with time to complementary feeding, and the fact that there was no relationship between complementary feeding and weaning, but also that it's very possible that in our data were collected from monthly interviews of, current feeding status, and introducing a bottle here and there, introducing supplementary foods may be much more transitional, which is very common of a gradual weaning population, by which I mean foods are introduced gradually and begin to accelerate over time, and then weaning itself is very gradual. Whereas we more traditionally think of infant feeding transitions in the WHO categories as these very discrete categories that you're in or you're not in, and that those decisions can be really rapid, or those can be very drastic changes, particularly weaning. But more broadly, I think there's also implications for recognizing that early breastfeeding problems, exclusive breastfeeding duration, and total breastfeeding duration are influenced by different biological, behavioral, and socio-structural factors. So this is all lactation, but different points of lactation are differently influenced by these factors. And so this brings me back to the larger question of what is suboptimal breastfeeding? Whether we're examining it in the context of how it might be related to cesarean section or any other risk factors, and how suboptimal breastfeeding itself might be related to later life health risks. So again, going back to as optimal feeding is defined by the WHO as these very discrete milestones that are reached. Those recommendations, of course, ignore important dimensions of breastfeeding, is that the optimum is lactation evolved as a trade-off between needs for mothers and infants, right? So there's always the possibility for maternal offspring conflict in that what is optimal for mom, any particular breastfeeding investment for the mother may not be optimal for her. And this is often, and these, in contrast, the recommendations, right, are explicitly modeled, are explicitly based only on optimal health outcomes for infants. So moms are by nature kind of ignored in those recommendations. And of course, every mom and every baby are different within and across populations. So there is, I bring this all up to say that there is there's an emphasis in public health and epidemiology on exclusive breastfeeding for 6 months of age as both a target that we should be meeting, and in research that uses exclusive breastfeeding for 6 months of age as a predictor of other health outcomes. However, we know historically from ethnographic populations in which breastfeeding was universal and there really there wasn't a lot of bottle feeding, that infants vary greatly in when they begin to introduce liquids and solids. And we can also look today and see in low and middle income countries that have pretty high rates of breastfeeding at 6 months and breastfeeding to 12 months, that those outcomes are pretty decoupled from two of the WHO indicators: early initiation of breastfeeding, so breastfeeding within 1 hour of birth, and exclusive breastfeeding for the first 6 months of life. Moreover, I'll add that across mammals, and including for humans, most lactation durations are this mixed feeding duration. It is not exclusive milk only periods. And if this is the real pattern, and if this is the real outcome, we can do a better job of emphasizing the factors that are associated with total breastfeeding durations than potentially exclusive breastfeeding durations, which don't necessarily correlate with that perhaps more important outcome. And I think this is particularly important in countries like ours, in the US, where you actually might expect a correlation between, or we do see more of a correlation between exclusive breastfeeding and then breastfeeding to a year or longer. But the problem is that it's mostly white, middle-class, highly educated women who are able to meet this milestone. And when we use that as an outcome, when we look at that in any analysis, relating that to some other health outcome, the analysis is automatically going to be confounded by class, race, education, and also values, because these mothers place a high premium on achieving that milestone. And in that sense, exclusive breastfeeding for 6 months might just be a costly signal, rather than a biological mechanism that really is affecting some health outcome. And a costly signal like that, we can't just control for in a large multiple regression. Another, I think, important implication of this work, of Abby and Katie and Brooke's work as well, is that there's a lot of emphasis, particularly in our country, but also globally, on breastfeeding success being tied to everything that is done in the immediate postpartum period, in the immediate perinatal period, honestly, as is demonstrated in this poster, in which the 10 steps to successful breeding all occur prior to hospital discharge. So my research that I presented today is not to suggest that early breastfeeding problems don't lead to continuing persistent breastfeeding problems, and can be a hindrance for women who want to achieve longer breastfeeding. I'm not even suggesting that across all contexts, cesarean section doesn't result in that. It certainly can. I've presented data from a very specific context, but rather we can learn from this that there isn't a necessary link always, that we have to do more, understand more about support for mothers and support for breastfeeding in the longer postpartum period, once mothers are out of the hospital and at home in their families, in their own communities. And so with that, I'd like to close with a framework for future studies looking at associations between cesarean section and breastfeeding outcomes. First, we likely really need to model these outcomes on explicitly defined pathways that consider the different types and causes of CS, of complement, of cesarean section, which our own work yet hasn't quite been able to do. You do need larger samples for that. So and this is important too in terms of policy implications, because it's potentially only medically unnecessary cesareans that would qualify, right, as a clear point of intervention. Right? If cesarean section happens because of premature birth or happens because of maternal or fetal risk, blaming the cesarean section for any later health outcomes is kind of a moot point, right? Because it was medically necessary. We also need to recognize then that feeding trajectories are fluid and individualized, that different mothers and their infants have different optima. And then we have to consider the local context of birth, postpartum, and breastfeeding practices, as well as how different families access and as well as how different families have differential access to certain services, values, opportunities, and preferences for birth and breastfeeding. And with that, I will be happy to take questions and have a larger discussion. Thank you.
All right, fantastic. Thank you so much, Melanie. Any questions from the audience? All right, well, people are preparing their questions. I, of course, have a multitude of them. I'm going to start with, so I'm obviously incredibly enthusiastic about your framework and recognizing the complexity of trade-offs and contexts within all of these events around the perinatal and breastfeeding. So I think the question is what's our, we rely on these kinds of like global sorts of recommendations that come from places like the World Health Organization and others that necessarily and understandably have to tailor their recommendations for global health contexts that are characterized by greater risks of infectious disease or differential reliance on groundwater, or a variety of different things. How do we effectively communicate the integrative complexity around these issues to different stakeholder audiences? And where do you find particularly useful messaging, and then where have you seen things kind of get twisted, I guess would be a big question that I have.
Yeah, I mean, I am completely sympathetic to needing, right? We all should understand that, right? Messaging needs to be equitable. It needs to be simple. And it unfortunately doesn't leave a lot of room for nuance, even, even though what we're talking about is inherently nuanced. I mean, I do think the messaging, like, for all the reasons I just discussed, I think I would prefer to see messaging and research on helping just continue breastfeeding for longer in that particular context. I think there's also ways of using that messaging to, and not just using the messaging, but using the research, right? But just really having a separation between messaging and research, which can incorporate that nuance. And that can get into conversations with healthcare providers, with communities, with lactation support, more so than the posters and these broader messagings, which are important in setting out policy, right? So it is kind of rambling here, but right, it is great to have a policy that supports exclusive breastfeeding for 6 months, because honestly, you need maternal leave for that to happen. And everyone would benefit from maternal leave, every parent, every pregnant person, every father. And so there are important kind of population metrics that can assist that, but that doesn't necessarily mean, somehow there needs to be some space then for people on the internet, for lactating people and their doctors, for families to say, okay, well, this is what we can do, and this is what we can manage. And our end goal is just to continue breastfeeding for as long as possible, and that works for us.
There are some comments coming in through the chat. So the first is from Madison Smith, who enthusiastically agrees based on the exclamation point. And she continues to say that she would go so far as to say this is a cultural issue. Breastfeeding has become overly sexualized, and many women are afraid to do it anywhere public, which probably motivates them to give up on breastfeeding earlier than they wanted to when they have to. I think this is mostly anchored to the particular regions geographically of the United States. But you get into a situation where if women are breastfeeding and they have their baby and they're out in public and they're being marginalized from that, then they basically are facing trade-offs between staying home all the time or not breastfeeding. And so do you have any comments about that how we change that kind of sexualized breast cultural issue within the US?
I think just more awareness and promotion, and unfortunately, it falls on all the lactating people to do this openly now, to change those ideas. I also think there might be another side to it. This is not anything I've investigated personally, but certainly when I think of how breastfeeding happens with the calm and the Tsimane in such open environment, especially if there are, say, problems with latch, which a lot of lactating people are going to experience early on, there's so much more stress around babies not being calm in the US. So I think and stress is a huge factor in letdown and lactation. And if you're out in public and your baby is super fussy, and you're already stressed about how people are perceiving you, and now the baby's crying, and like maybe that leads you to be like, okay, we just can't do this, so I can't go out in public. That right then cuts my opportunities for nursing, or I can only give them a bottle out in public. And so there just might be, you know, more, it builds into that acceptance, might be more acceptance of the struggle if there is one as well.
Diana Bueno has a question about, so thank you, great presentation. I have studied breastfeeding determinants in Tijuana, Mexico and in Central Mexico, and I wonder how useful is it to have a strict recommendation for exclusive breastfeeding for 6 months. Here in Tijuana, I see that making that recommendation sometimes is not practical to mothers' context and generates a lot of guilt and frustration. It continues that Dr. Bueno is a medical doctor and also sees that we need a better that we need better medical training, because sometimes we just focus on the EBF for 6 months and not take into account mothers' realities. Comments from you about that?
Yeah, I mean, I completely agree with that. I think there is also should be, you know, acknowledged in what I was alluding to it. Then it can also be a privileged position when individual mothers really value exclusive breastfeeding for 6 months, or value breastfeeding as a signal of doing what is best for your baby, because there are so many barriers for other lactating people to breastfeed and continue to breastfeed. But I don't want to downplay that very genuine guilt and frustration they feel like when that happens. And there's a balance still in our country, and I think in many other countries too, where there has been such a break in the traditional practice of breastfeeding. So where bottle feeding has become very prominent, that it then also becomes very easy in the medical profession and among family members and others to say that, oh, it's fine, or, you know, your baby doesn't need to breastfeed, or, you know, there's all of these angles kind of intersecting. And I think there just has to be space between a recommendation that is clearly aimed at population metrics and policy that can inform those population metrics, versus discussion and understanding, and with doctors as well, that individual trajectories are so much more varied than that. And there's a lot of ways for infants to thrive. You know, breastfeeding honestly isn't critical to that. And there's hopefully other ways that mothers who might be struggling particularly can feel celebratory about the ways that they are feeding their infants and other ways that they're caring for their infants.
Right. Good to see. Kalen has his hand up. Kalen, do you want to ask your question?
Yeah. Hi. Thank you so much for that. I was curious, and I hope I didn't miss it, and I'm asking something that you mentioned, but I was curious about the rate of cesarean section in the population, and maybe how that compares to other regions in Argentina, or if this is something that is sort of, I don't know, a local, it almost seems like concerning in a way, maybe at that level, and if there's structural reasons why that's happening, or if you have any sort of anecdotal thoughts on that, or.
Yeah, it is definitely concerning. We don't have the real local understanding of, so within that, the hospital that the Colm women are giving birth at is the only public hospital, but that serves all women who have public health care in Formosa, which is the population of 100,000 people. So I don't know if that reflects the hospital itself, or if that might actually be higher for Colm mothers or lower. It is pretty consistent with Latin American rates in general and Argentinian rates. Right now, Latin America has the highest rate of cesarean section in the world, and it has also seen the most rapid increase in cesarean section. There have been studies showing in certain private hospitals in Argentina rates as high as like 60, 70%. So there's a lot of things that have been documented, you know, here too, medical incentives for cesarean section, or I should say like financial incentives for the medical industry, for the physicians, and a lot of probably paternalism coming from the OBGYN. You know, we are particularly concerned with it with the co moms because, you know, we know that many of them don't have the education or necessarily like the standing in that environment to understand what they might be told about why they need a cesarean. I didn't bring it up here, but so in this paper that we're working on in progress and from those retrospective interviews, most moms did remember why they had to, with the moms who delivered cesarean, most of them did remember the reason for it. Most of them were scheduled cesareans. About 70%, I think, were scheduled cesareans. And the reasons that they reported, that they were told, some of them were, you know, they sound reasonable. It was like gestational diabetes or nuchal cord, or, you know, things that are traditionally risk factors for cesarean. But there were some others like some moms had low blood pressure, anemia, like those are not medically justified reasons for a cesarean. So we would need to know a little more, and this, you know, is the research we have done with this fairly small sample is kind of impetus for going in the future, and hopefully working within the hospital itself to understand more comparatively across Formosa what might be going on. Interestingly, I can also add, for the co-moms in the West, so which is a little more rural and isolated, since COVID, they've all been giving birth at home. And the link, there aren't any, you know, kind of practicing midwives anymore in any of these communities. So that's a whole nother avenue to explore now. I don't know how this might have a positive change towards that, maybe in the future.
Fantastic. Virginia, do you want to ask your questions, or do you want me to read them from the chat?
I'm sorry, I'm on a small island, so I'm happy to, this mode is always very odd for me. I really enjoyed the information you presented and thinking about it and that long-term view that you took. The one thing that really strikes me about the either or of how much women should breastfeed is that it's constantly placed on their shoulders. You either should breastfeed for exclusively for 6 months, and this is the rule and you must follow it, or somehow there's no, you know, I think as long as possible, again, is saying the onus is on the woman to behave in a particular way. Whatever her other obligations, her desires, her goals in life might be, her obligation is to behave in that way without any kinds of changes in structural factors. And I've now been seeing this for literally 35 years in this kind of research in anthropology, where again, it's constantly upon the woman to do that. And I don't know about the population that you've been working with, so I don't want to presume what they might need, but I know with the Aymara and the highlands of Bolivia, you know, it's just, they're told this over and over again, despite the needs to take care of herds, to take care of agricultural fields, to take care of other children, to deal with all kinds of political issues in their communities, and to deal with the lack of resources, et cetera, et cetera. And I'm sure you're familiar with all of this, having worked where you have. And so I wonder how we can get that message, what kinds of messages might be possible to structure that make it a broader issue, that bring in structural factors, that consider these things instead of constantly dumping all the responsibility on an individual woman to somehow manage these demands about how to take care of her child.
Yeah, no,
that's a very demanding question, so I don't expect you to solve it.
I absolutely agree with you. I try to emphasize in the work that I present on the Tsimane and the Kom, that their whole context of breastfeeding is so different from ours. Yeah. That on the one hand, to emphasize, like, we can't just apply what they do to women in different contexts, because their social environment is conducive to patterns of care and feeding that we don't have. Mm-hmm. that would be part of it. But was other things that you were saying, I mean, I also think if we really think about maternal optimum and center maternal optima, we tend to do that here, I think in the US, in the sense of more in a way that is like choice, which is not helpful to anybody, and then, sets up this whole debate of conflict about who's a good mother and not. But, it tends to get framed around maternal choice and freedom and feminism, honestly, when there is, I think, a much more urgent focus to focus on maternal trade-offs in terms of her other obligations and the other ways that she's providing for her kids. So work, caring for your other kids, other family care, as well as individual well-being that is different for every lactating person. I don't know yet how to frame that in a way that reaches people, but that is, yes, that is what we need to be talking about and considering and acknowledging for all, families that are navigating how they care for their children.
We're on the same page, and I don't think that I have a solution either. So, I just think it's really important to remember women are more than lactators, moms are more than lactators, and that the focus on how she should lactate and her enormous responsibility for the offspring, and not bringing in the other kinds of opportunities and not the other considerations that I think really need to be brought to the fore, particularly in a world that rapidly transitioning to different ways of lifestyles, even in the most remote regions of the world. But thank you very much. I really appreciate your talk a lot.
Thank you.
Yeah, and following up on Virginia's point, I mean, one of the things that I think is really missing from the dialogue in high-income countries where you see, where we're post-demographic transition, the benefits of breastfeeding in terms of the effect size on improved health are seemingly likely to be greater for women than necessarily for the baby. And so, or the lactating person, we don't have as much information about the downstream consequences for reductions in diabetes and metabolic syndrome and other kinds of reproductive cancers. But part of the messaging, the messaging doesn't include how it's good for women's health too. And that I think is very, very telling about who's largely being excluded from consideration around a lot of the public health messaging. So
yeah, I think you can also add to that. It's good for the environment. Like it's just much lower carbon footprint to cannibalize yourself than to get it from cows and manufacture it. So if there's a societal interest in a lower carbon footprint, there should be a societal interest in enabling more families to breastfeed if that's what they want to do.
All right, well, fantastic presentation. Wonderfully dynamic dialogue. And now we're at the end of the hour. So please, everyone, join me again in thanking Professor Martin for her presentation.
Thank you all.